Bismillahirrahmanirrahim. First of all, I'm very thankful to Dr. Salman Sharif to giving me opportunity to present here the experience of my last 12 years. Actually, over the last few decades, gamma knife stereotactic radiosurgery has become an important treatment option for patients with benign and metastatic lesions of the brain. Gamma knife radiosurgery is a specialized technique that delivers highly conformal radiation to the targets with sub-millimeter precision. When initially introduced, large doses per fraction in stereotactic radiosurgery defined conventional wisdom in radiation biology, and fear of the late radiation effects was prevalent. However, both prospective trials and retrospective studies have shown that stereotactic radiosurgery can achieve excellent local control with acceptable toxicity for both metastatic disease as well as for benign conditions. The technique has been recently adopted to treat lesions outside the brain and it's called stereotactic body radiosurgery. And I invite you to see you have seen the frames of skull, but you can see the body frame as well. We have got stereotactic body frame as well. MashaAllah. Now, how this gamma knife radiosurgery progressed? It is continuously progressing from the prototype 1, prototype 2 to model B, and then model C, model perfection, and now icon. Here's gamma knife 4C. We bought it in my, started in my 5th, 2008, and it worked till September 2016. As you know, there are, sources placed around, about 200 sources around, and there's time decaying and the half-life increases. So you have to change the sources. But with the grace of God, we changed the machine. And he was our first teacher of gamma knife, Professor Lars Carlson from Sweden. And he did first case on 7th of the May, given a dose of 18 gray to a metastatic lesion. This is a new icon now available at NCCI. Since 2016, we are working on it. It's a new device, a new workflow with cone beam CT, truly stereotactic frame or mask. You have got both the words now. Constant real-time tracking of patient position via stereoscopic infrared detector, high-definition motion management. Here is the cone beam CT. You can see the target and localize where you are placing the target. It's at a fixed place or not. And here is the high-definition detection. And here are the detectors. Here are in the previous one, the collimators were being used manually, but now we are using, it's totally automatic machine with automatic collimator system. And now you can say in icon gamma knife, you have got 2 words. On left side, you can do a small crater formation like for thalmotomy. And on the other side, you can do higher lesions with multiple frictions. So you have got the best of 2 words. And this is, as I was asked to tell you about 12 years experience, this is the foramen magnum meningioma. We treated with 25 gray at 50% with 5 frictions on May 5th, 2021, and completing the 12 years with grace of God. Now, total cases we have treated 3,578 cases, and male 58%, female are 42%. So about 300 patients per year and 25 patients per month we are treating on gamma knife. Age range 3 to 80 years. Gamma knife as a first line of treatment we have treated only in 56% of cases, and as a second line of treatment after operation or radiation, 54% of cases. The median Kronsky performance score of the patients was almost 80. Here you can see the lesions we treated. Most lesions are AVMs, then lesions are the glial lesions, and all sort of lesions we have treated, but the common, I told you, as a glial tumors around the brain stem or so where we can't reach by surgery. And the location of lesion common around the brain stem and other regions as well. The minimum dose, you know, the 8 gray to 10 gray is acceptable dose, and minimum dose was, you know, in the most of the cases, 120 cases. And the maximum dose we used in trigeminal neuralgia, like 94 gray. And for thalmotomy, we have started the functional neurosurgery as well. We can go up to 140 gray as well. Now, vestibular schwannomas, total number of cases was 394. Male-female ratio was 263 to 231, age 24 to 70 years, and subtotal or partially excised tumors was 17% only, and rest of 83% were as a first line of treatment. Size ranged from 334.2 to 28 millimeters. Symptoms at presentations were hearing loss in 90% of the cases, tinnitus in 42%, vertigo 35%, balance symptoms ataxia 45%, facial dysfunction 24%, other neurological deficits 19.5%. Treatment planning, we used most of the cases 10 to 14 gray with 50% SO dose located at the tumor margin. Median prescription dose at 50% SO dose was 12 gray. In results, there were central necrosis or loss of the announcement were in 72.3%. Decreased or stable tumor was found in 80.2% of the cases. No facial nerve toxicity was observed. Temporary non-specific vestibulocochlear symptoms were reported in 43% of the cases, or 10% of the cases. Surgery after gamma knife were done in 4 cases only, in 1%, and in 1%, actually, when we see there is obstructive hedocephalus, we used to ask the patient first do VP shunt. But in only in 2 cases we did the shunt after, because there was a pressure after radiosurgery. This is the acoustic schwannoma. You can see central necrosis, Second case, central necrosis after 6 months and almost complete resolution of the tumor. Again, complete resolution. Again, a case with having the we did it in 2012, and we did follow-up in 2013, 14, 15. So we did accurate radiation delivery, and it was a conformal dose and selective radiation delivery, powerful intratumoral effect. Margin dose of 12 gray keeps cranial nerves morbidity below 5%, facial weakness less than 1%, hearing preservation in 50 to 75% of the cases. Gamma knife for meningiomas. Here you can see a 54-year male with parietal meningioma, and we given a volume was 14.1 cc, 12 gray dose with 50% SO dose line. And here's another case with meningioma. Total cases were 378. Male-female ratio were 159 to 209. Age range 14 to 85. Average age was about 45 years. Residual or recurrent, we treated 31% of the cases, and primary 69% of the cases, and the skull base tumors were 62% of the cases. Now you can see the higher percentage is the paracellular sphenoidal ridge. I mean that the difficult one which have left by the surgeons, or is we could not approach because of the vicinity of the vessel and the nerve. And the median tumor volume in meningiomas was 13.4 cubic centimeters. Median tumor margin dose was given 13 gray only. The patients were assessed clinically and radiologically at routine intervals following gamma knife radiosurgery. Results follow-up was 15 months at the mean in 320 patients. Decrease in size was found in 73% of the cases. Unchanged or stable tumor were found in 25% of the cases. Increase in size in 8 patients, 2.4% of the cases. Complication occurred in 14 patients. It's 4.2 only, including fits, transient cranial neuropathy, and symptomatic edema. Now the craniopharyngiomas. Craniopharyngiomas, second case. This is a third case with follow-up. Now the in craniopharyngiomas, male and female 52 to 23, consistently solid were 18%, cystic 13.3%, mixed 51%, and prescription dose was 8 to 14 grays. The results excellent in 32%, good in 48%, fair in 12%, and poor in 8% of the cases. As in craniopharyngioma, significant tumor control can be achieved if radiosurgery is systematically combined with limited tumor resection, cyst drainage by neuroendoscopy, or reservoir placement. Treatment-related neurological deficits are rare. AVMs, second case, and you can see the resolution of AVM with the passage of time. I don't have enough time, and here is the initial reaction of the gamma knife radiosurgery. Lesson learned in AVM. Obliteration rate at 3 to 10 years varies between 55 to 98% after a single procedure. Repeat SR is required in 10 to 35% to achieve obliteration. Large volume AVMs require multiple procedures. Complications are late only. Associated aneurysm require additional management. Hemorrhage rate decline after stereotactic radiosurgery, approaching 1% only. Hemorrhage risk during the latency interval after SRS is not increased. And now the functional neurosurgery, most of the cases are trigeminal neuralgia, more than 100 cases. And then Parkinson we have done psychosurgery, we have done epilepsy surgery as well. I'm showing you this is a trigeminal, how we get in on the MRI. And here is the functional neurosurgery for the tremors. We do thalmotomy. Again, here is the epilepsy surgery we do when we see on the PET scan, on the EEG, and we confirm it from all the way. Then we do also the epilepsy radiosurgery. And here is the after radiosurgery. Again, we have done also in the complex partial scissors on multiple, and we did also the dissection of the corpus callosum with the gamma knife. Here, the gamma knife capsulotomy, and total we have published 11 publications, one monogram, participation in internal conferences 20 times, in the national conferences, this is 12th time. And here are my mentors, my professors, and my first professor who I think professor who are familiar with the functional neurosurgery knows Professor Chirio Oe late. And this is Sherman. My last training, Professor Regis from France. I went to learn the functional neurosurgery 2 or 3 times with him. And again, the giant of functional neurosurgery, Professor Marvin, is a minus 16 degree temperature in Sweden, Umeå. 2 years back, I went to work with him and Professor Peter at Umeå University. Now the conclusion, the gamma knife radiosurgery is a non-invasive technology useful in the management of multiple types of cerebral lesions. It is safe and in many conditions highly efficacious. At NCCI, we have treated more than 3,500 patients with a variety of brain lesions, and results have been excellent in the majority. Use of gamma knife is expanding, and the technology may have a future role in the management of functional brain disorders, psychoneurosurgery, as well as epilepsy and Parkinson's disease. Thank you very much.